So if you've got a patient coming into your clinic with chronic fatigue syndrome or M.E, are there any sorts of testing that you would do, common types of testing that you find particularly helpful?
Well, the first thing is many patients have had lots of tests done already, and important clues within those tests have been missed. So, for example, the reference ranges for normality have now changed. And the way that we establish those reference ranges, excuse me, is by looking at, 100 people that come into hospital. What are their results? Oh, that's the normal range. But guess what? 100 people coming into hospital are not normal. In fact, anybody who is eating a Western diet is no longer normal because they're not eating an evolutionary correct diet. And throughout my career as a doctor, the reference ranges have changed enormously. So, for example, when I was at medical school in the 1970s, one of the measures of inflammation in the blood is called an ESR. A normal result is considered to be an ESR of 5 or below. For some laboratories, that is now 30 millimeters per hour or below. It's set far too high. Similarly with the underactive thyroid. Now, the thyroid is our accelerator pedal. It's the accelerator pedal that controls our mitochondrial engine. And the normal reference ranges for levels of thyroid hormone in the blood have dropped hugely just in my career. As at the time, the lab I tend to use, reference range for a free T4, which is the active thyroid hormone in the blood, is about 12 to 22 picomoles per litre. But some laboratories, it's as low as 7 to 14.
Yeah.
So many cases of the underactive thyroid are going to be missed. So the first thing I say to my patients is, don't spend any money on tests. Give me all the tests you've already got and let's have a jolly good look at them and see what's going on. Now, of course, what you have to remember is that the patients that I'm seeing, so often they're so fatigued that they're unable to work and they are very short of funds. And I would much rather they spent their money on good food, sorting out the gut and good supplements before they do any tests at all. And this basic workup package I have for treating patients with chronic fatigue or M.E doesn't require any tests at all. You just work your way through the regimes, which are detailed in the book. So, for example, I learned about mitochondria, as I said, in the 1970s. I realised in the 1990s that they had clinical application. And in the 2000s, I worked with the most brilliant biochemist in the world, Dr John McLaren Howard, who developed a test for mitochondria. And what we showed with that mitochondrial, let's test the engine test, is that the more fatigue with my patients, the slower their engines were going, and vice versa. And that was we wrote up a paper about that was our first paper. The next thing we had to ask was, why are those mitochondrial engines going slow? And a very important reason for why they were going slow is because they don't have the raw materials to function. They've got the wrong fuel in the tank.
Yeah.
And how do we treat that? With diet. Now, we measured the common deficiencies that we know impact on mitochondria, like magnesium, like coenzyme Q10, like vitamin B3. We know that if you're deficient in those things, then your mitochondrial engines will go slow. And since those early days, I've now done 1,036 of those tests. And I now know what the regimes are to correct the mitochondria.
Yeah.
Now, at present, we don't have access to that test. The laboratory is closed at the moment because John is looking to retire. But it doesn't matter. We can still get patients well without having access to those tests because we know what works.
Yeah.
And that was the subject of my first book. My patients loved the title of it, Chronic Fatigue Syndrome. It's mitochondria, not hypochondria. That went down very well with my patients.
That's brilliant.
And again, it was the first objective evidence that this is not a psychological condition.
Yeah.
This is a pathological condition. The pathology is at an atomic level. It's at a very, very tiny level. So we can't see it. We can't even see it with microscopes. Mitochondria are tiny little cell organelles that are difficult to visualize. But just because they're difficult to visualize and look at doesn't mean we shouldn't be searching at them. Doesn't mean we shouldn't be investigating them and looking at them. So mitochondrial function tests have been a fantastically useful tool, and that tells us that this is not a psychological condition. This is pathological.
That's fantastic. And I actually really wanted to come back to what you said about the reference ranges. That's such a key thing for people listening to understand, in that those reference ranges, like you said, are based on the average patient. Does that mean that those are based on optimal levels for your health? Absolutely not. So when we're, in clinic, I think it's always good. I always say to patients before, when they book in, bring any test results you've got, because we may draw a different conclusion from those. The thyroid is a great example, because as you've said, the thyroid, and certainly in your protocol, you put great significance on looking at the thyroid and addressing that if necessary, which is common. And I think also the TSH levels, which is another parameter, which stands for thyroid stimulating hormone. You may correct me on this, Sarah, but I think conventionally the normal range is something like less than 4, I believe, if I'm not mistaken. Whereas, optimal ranges, we're generally looking for more like less than 2.5. So, it's interesting. Somebody could come in with a range that appears to be normal. They're told it's normal, but it's not normal. So important.
The single most important aspect of testing the thyroid is to make absolutely sure that patient is not thyrotoxic. Because the point here is that all diagnosis is hypothesis. When somebody comes to see me, I hypothesize that their diet is wrong, that their mitochondria are going slow, that the thyroid accelerator pedal is running at 15 miles an hour instead of 60 miles an hour. But blood tests are never definitive. We then have to put that to the trial. And so we put in place the treatments we need to correct the diet and gut function, to correct our mitochondria, to correct our thyroid glands. And if that patient improves as a result, then we can say we've got the diagnosis right.
Yeah.
Yes, that was the mechanism. We've corrected with this. The patient is cured. Off they go.
Yeah, makes sense.